not be safe until the effective and affordable vaccine is available to the whole world or the world develop herd immunity. So this is the current situation. We are hopefully in the near normal in our country. We are trying to adapt a new normal with only this area, this Karen state border with Thailand, where a lot of returnees coming back from working in Thailand has more than 20 cases, positive cases. But the rest of the country is only few positive cases. So what about what about the following days where we are afraid that another wave might come in, hit our country because the public compliance is getting low now. That people tend not to wear masks in, when going outside or and when international flight resume, and we are expecting that the cases will be coming back because we have only 3 incidents of local transmission, and all the infections started from the returnees, were imported or something like that. So in conclusion, well, so anticipation, preparedness, and timely collaborative actions by the government, health workforce, volunteers, donors, and public, and a good leader help us controlling the spread of COVID-19 in our country. However, we keep in mind that our achievement was only half due to our work, our efforts, and half due to our luck. So we have to work harder and to comply with the instructions to prevent occurrence of second wave in our country. Thank you very much. So, hello.
Okay, then you
Professor Tun,
Thank you.
thank you very much. Amazing to understand how really Myanmar and later we were thinking that maybe you have many more cases. Why in reality not too much. Let's move on to Professor Naeem. So then we will have a discussion because the topics are similar.
Yeah. Okay. You hear me?
Yes, I can hear you very well.
Okay. I share my screen. Can you see my screen?
Yes, Naeem, we can see your screen now. Sorry.
Okay. Okay. So thank you very much, David, Sute, Alan, and all of my friends. And Dr. Thun just presented a beautiful presentation, and where Myanmar was much better off than Bangladesh. But anyway, what we learned in Bangladesh, in a nutshell, I just want to try to tell you. Sorry. Okay. Hello.
Yes.
Oh, somehow it is stuck. Yeah. Okay. Fine. Well, remember that life's greatest lessons are usually learned at the worst time, and COVID-19 crisis probably the worst global crisis that we have faced in our lifetime. And actually, I always think that we never imagined as a doctor, out of treating or operating a patient, we might die, our family might be involved. So about Bangladesh, well, it's a very small country with a huge population bounded by mostly India and part with Myanmar. In a nutshell, the current doctor-patient ratio is, as expected in Bangladesh, very low. And also the number of nurses, even worse and the hospital beds and the ICU facilities was not at all up to the mark to fight the uh, situation, COVID situation like this. In Dhaka city only, uh, why we were so vulnerable. It's a 20 million population, and around 3 million is living in impoverished urban settlement and slums. And the public transports are hugely uh, crowded. Physical proximity and shared facilities can be avoided. So, while many countries define the problem, but still fail to respond, that we know. But countries like US, Italy also uh, define the problem as lack of preparedness. But flattening the curve was important for everybody. At that point, the question is Bangladesh, how Bangladesh did define the problem. Well, government actually had three options. Two of them was not possible, eliminate the crisis and status quo. So government had to go for containment. And from the very beginning, it was important to clear the containment program, what it is. For the present situation, on 8th March, our first case was diagnosed, confirmed case found, and on 18th March, our first death from COVID. And as of August 12, the total diagnosis is 266,498 according to the government. You'll have to think that all these data are by the government, and we believe the number should be much, much more. And the total death is 1.3% only. Still, the total recovered is around 60%. And recently, in a population of 160 or 70 million population, we are only having 10 to 15,000 cases tested, and our positive rate is about 25%. So what measures we should have taken strictly by the government? Government had many committees, and our health ministry, health directorate has worked very hard on it, but still the complete lockdown was absolutely necessary. Instead, government declared a general holiday. So people were not really very uh, aware of the situation. Effective quarantine uh, was not done from the very beginning, and tests were very low from the very beginning. And diagnosis, isolation, and contact tracing and isolation quarantine was not effectively could be done in our scenario. And then we talk about treatment. The complete lockdown was absolutely necessary, as I say, and general holiday, the people were asked to go for, social distancing and protocols, everything was uh, well was declared on media, but because the concept of this by ordinary people was probably barely understood. And during mid-May, more damage was done when the economy was open. Life and livelihood both are important at the same time. And self-quarantine was advised. The Bangladesh also has a huge number of expats from different part of the world, and people are working outside. And due to the outbreak of COVID in different countries where Bangladeshis are working, people came back, and from our government, actually, institutional quarantine was not possible because facilities were not ready. At the same time, IEDC as an organization, as an Institute of Epidemiology and Disease Control and Research Center and Director Cell told us to go for, the people to go for self-quarantine, and which was not strictly done. And the test, who also told the test, and test, and which could really save us a lot. But initially, from the beginning, government entrusted only IEDC. I told you, it's of Epidemiology and Disease Control and Research. They carried out the test and declared the number. Private hospitals and other organizations, actually, which gives the nation's two-third health service, still were not allowed to go for RT-PCR test and declaring the result. Eventually, IDCF failed due to the huge rush and demand of the test, and government allowed eventually private healthcare sector after 3 months of having the first case, the end of May. We understand problems are manifold in RT-PCR test. You know, RT-PCR test is not a simple test, need particular level of biosafety lab, need trained people of different level, and also for Bangladeshis, it is important to think that cost is important. As a result, very low number and patients they don't also agree to go for test, false negative for many reasons are hugely huge. I mean, more than 35 to 37. So diagnosis, contact tracing, quarantine, and isolation. You know, the social stigma was another main barrier because the patient and the families were uh, faced a social harassment. So they didn't go for quarantine. They didn't go for declaring their problems, and minimal cooperation from the patient and patient's family for testing, quarantine, isolation was a big factor. And that's how we really fell into big trouble. And regarding treatment facilities, government at the beginning uh, asked all of us only to send the COVID and COVID suspected patient to COVID dedicated hospital. And no other hospital was allowed to accept COVID patient, but eventually we are not allowed to do the test. These were some self contradictory decisions also we had to face. But you know, at the beginning, ICU beds and ventilators were the main concern, but later we could understand that only oxygen with high flow nasal cannula and some other way was more important. Supportive treatment also was important. And initially there was a huge rush for hospitalization, but nowadays we see almost 70% of the hospital beds, even in government sector, are empty. And rather telemedicine, video consultation for minor symptoms are more popular. Bangladesh might have some few protective factors, what we believe, because after having such a huge population and even in slum areas, you know, the prevalence, we believe the death rate is still very low. And another reason is only 7% geriatric population, and probably our hypertension, obstructive lung disease, coronary heart disease, diabetes is also well not very high. And another probably another factor was expanded uh, uh, program of immunization, which Bangladesh very successfully did from 1979, especially the DPT, OPV, TT, and measles vaccine might really played a role, but we are not yet sure. And Dhaka slum is still where COVID is curiously quiet, and why do slum appears to have fewer COVID cases? We still do not have any answer, but we're feeling it. One very bad and very dreadful thing is the doctor's plight was mounting in Bangladesh. In Bangladesh, with at least 110 doctors, including a good number of surgeons having died due to the disease. It is very sad for us. We have lost quite a good number of our colleagues, our seniors, and very close friends, uh, mentors. And it was due to probably less test and diagnosis, failure of doctors to take adequate safety measures, exposures to the patient unknowingly, faulty masks, PPEs, and other protective equipment. Very unfortunate. And other issues probably the doctors who were working in the COVID hospitals were insufficient health safety gear, proper donning, doffing, arrangement for treatment, transportation facilities, residential safety. But I believe we have seen the more doctors were infected in the non-COVID hospital rather than in the COVID hospital. Because in non-COVID hospital, probably they got infected willingly. So now about 3,000 doctors have already contracted the virus, and well, totaling about 8,000 health workers in a country like Bangladesh, where these people are scarcity of these people are huge. So it is a great problem for us. So now we are thinking about how to resume our work. We are talking. It's been 5 months. We need to move forward. The new normal situation. Lots of discussions are going on. Having proper negative pressure OT with proper smoke evacuation system in all places is practically impossible. Our surgeons, especially young surgeons,